Hi, welcome back. This is Gerald Major reporting from hashtag #CArthritis at the 2019 Canadian Rheumatology Association and Allied Healthcare Professionals annual scientific meeting. So it's my pleasure to be sitting beside my rheumatologist and the current president of the Canadian Rheumatology Association. So Dr. Ahluwaila, please introduce yourself and why are you in rheumatology?
Oh, well, thank you very much for this opportunity today. So I'm a community rheumatologist and I work in Brampton, Ontario. I've been there for over 20 years. And I graduated from the University of Toronto, did all of my training there in rheumatology as well, did an extra fellowship in lupus. So I have quite a bit of interest in all areas of rheumatology, not just lupus, but all areas, because as we work in the community, we see all aspects of rheumatic disease. So why am I in rheumatology?
Yeah.
Is that
What are you doing here? What's your role?
in rheumatology in general,
Yeah.
or like just in...
Why rheumatology?
Why rheumatology? Well, that was interesting. I think Dr. Keystone was one of the people who inspired me initially. I was a clinical clerk and I did a rotation at the Wellesley Hospital many years ago, and we were part of this sort of like case discussions of all the admitted patients, and I was very impressed with the interesting diseases, the immunology of rheumatology, and that kind of brought me into thinking about doing that as a specialty. And I have no regrets. I think it has been a wonderful time. I'm very passionate about my my job, and I love the patients that I take care of.
So last night's event was special. I noticed that you started calling out the different committees, and you just kept going and going and going, and people kept standing. So talk about, just the CRA and the structure and the amount of work that goes into this.
So I have a little bit of experience from association perspective. I was the previous president of the Ontario Rheumatology Association. So about a year ago, I started as the president of the Canadian Rheumatology Association. And it's been a wonderful experience. I think that the rheumatologists are really a family. They're a great community of physicians. They love working together. They love collaborating. They love collaborating with allied health and patient groups and everything, and try to bring everybody together to get the best care possible for our patients. So last night at our gala, we were putting up the names of the people who are involved in the various committees. We have about 10 different committees that do a lot of great work. We have board members, we have board committees, we have other activities under our umbrella, including Residence Weekend, the Future Leaders in Training in Rheumatology. So we have a whole bunch of programs, and there were so many people involved in that. So what we did last night is we asked everybody, when their name came up on the slide, to stand up, and by the end, pretty well, right, most people were standing who were members of the CRA.
And that speaks to the engagement of organizations.
Exactly.
So this year's theme is building bridges, and what does building bridges mean to you?
I think building bridges means a lot about bringing groups together to do various things. That could be researchers, that could be clinicians, that could be different types of organizations, whether it be the AHPA, whether it be ACE, whether it be the Arthritis Society, and so forth. So those are the kind of things we want to foster, because it's really through collaboration that we're going to do a greater good.
A lot of the people that we've interviewed kind of share the same types of experiences, and we have people that are crossing between pediatrics and adult care, and pediatrics is in a great place right now with funding. As you know, you introduced me to Michael Mallinson 3.5 years ago or so, and then I became an advocate. What it's allowed me to do, though, is also see things change in a short period of time. So I've seen the excitement around the CRA changing. I've seen the involvement specifically changing. I've noticed the impact of these different groups like the AAC and the patient groups. I feel that there's much more inclusion of patients, and through those short years, I think the new term when I arrived was patient-centered care, and I couldn't understand that was new. But what are some of the things that you've noticed over the years in rheumatology? As you know, I mean, it was a tough gig for a while with not a whole lot of medication, and it kind of really seems like it's arthritis time right now.
Well, see, you hit it right, the nail on the head, because I think that this is the best time to be a rheumatologist. And I don't want to say that anybody should have any disease at all, right? But if you do have arthritis, we have fantastic treatments. And if we see you early, which is the key, right? Early diagnosis and early treatment is really the key, because then we can get you on treatment that's going to put you in low disease activity or remission, and that's our goal now, in a shorter period of time, and maintain you in that state for a longer period of time. So it's really important we have fantastic armamentarium of medications. And what's interesting is rheumatology didn't really seem to be, if you could say, glamorous specialty. You know, cardiology was always like acute care, things are happening and that sort of thing. There are other procedural specialties people may prefer to do, but ours was, not as popular, if you could say. Now we have more applicants than we have residency positions to offer. And that's because we do have so much to offer patients.
So patients are in great hands.
Yes.
So you've been a pioneer of models of care, and we've interviewed a number of people over the years. And what I've seen is you've got similar models adjusted slightly depending on the lifestyle of the rheumatologist. So speak a bit about models of care and what we can expect to see, because we have pockets across Canada where people don't get this type of care. So speak about maybe the challenges of distributing that model across Canada.
Right. So models of care sounds like more of a generic term, right? So what we're really kind of trying to do is to build interprofessional team-based care. And we have started to see that in family practice. So the family doctor doesn't practice in solo. They have physios and OTs and dietitians and maybe social workers and things like that, because really patients need much more than just a drug. They need so many other things that are going to make their health better. So when we look at rheumatology, we are generally an underserviced specialty. So as I said before, we probably don't have enough rheumatologists. And if I say probably, I can actually back that up by saying that we've done a survey where we've looked at the number of rheumatologists in Canada. It's called Stand Up and Be Counted. And we have a benchmark, which is one rheumatologist per 75,000 population. We don't meet that in any province, in any area. So we know we're very underserviced. But having said that, the question is distribution of rheumatologists, right? So a lot of rheumatologists who are researchers affiliated with universities may be in certain urban areas, but we don't have enough rheumatologists in perhaps communities and rural areas and things like that. So the distribution of rheumatologists could be better. The next thing is, maybe we don't have to increase the number of rheumatologists. Maybe if we had a way or a mechanism of being able to triage those patients that need to see us and to need to see us earlier, then we could get those patients in and get them on treatment. Sometimes certain conditions, I mean, in Canada we know it's hurry up and wait, right? It's always like a waiting game, and patients are used to that. And it shouldn't be a waiting game, as Andre Picard told us the other day, that we shouldn't be waiting. We shouldn't be accepting that wait anymore. So we have extended role providers that are certainly helping us triage patients a little bit better so that we can see the more urgent cases earlier.
And then we'll fold the patient groups in that and save you another 10% on the managing outside of the appointment.
Yes, exactly. So that's really important, because you'll see the doctor once every 3 months or once every 6 months, or what do you do about your disease? the rest of the time, right? And so through the patient groups, we have learned so much. We have learned about self-care and self-management. We have some role models. We have so much education that is possible. And we also have literature that allows patients to go to reputable websites, to do appropriate exercises, all those kind of things that are important for self-care in between visits.
So I can't let you go without asking you about medical cannabis. You released your position statement. I'm not sure if you saw my review on it from OBRI, but I thought it was very positive and very fair. I thought it was cautious, and it was a call out for research. At the end of the day, much more research, and they have to figure out the research part of that for sure. But you ended with prescribing guidelines, which I thought were, a compromise within the CRA on if you were knowledgeable of it and you saw effectiveness of it, or better yet, if the patient was knowledgeable and would start that conversation, then you'd be supportive of it. So talk a little bit about that.
Sure. So we really, at the CRA, we really felt that we needed to publish a position statement on medical cannabis, even though it's not really a regulated drug.
Right.
You're right? So, but we know that in practice, many patients have already been taking medical marijuana. Medical marijuana has been around for a decade, right, or more. So it's not new. It's the recreational piece that came out in terms of being the new piece of last October. So in that sense, patients are already taking it. And in fact, patients would come in every 1 to 2 weeks and tell me the fact that they were taking medical marijuana but really hadn't mentioned it before and stuff, and that their pain was managed better and stuff. So I think the first thing to understand is really that it's not a substitute for standard of care for rheumatic diseases. However, pain is not treated as well as we think it is, right? And pain is still a chronic problem. We don't have good treatments. We have an opioid crisis, we know. So we reflect back on our patients who've taken those, and maybe there should be some other things that we should be prescribing it better. So from that sort of point of view, we felt that it was very important to take away our biases, to offer an empathic view. And although we don't have lots of evidence on medical cannabis, maybe for those patients whom we feel it might be appropriate, there's some guidance in this position paper for physicians to use. Now, many of our physicians do not prescribe it, and in that case, at least they can refer to the appropriate cannabis clinics and where there is expertise, but at least when they come back to us, we have some guidance as well. Right?
And I think it's important to note around I think the frustration could be patients coming in and saying, I've stopped all my medication, I'm now using cannabis, and that's really not what we want.
No.
I understand all the research, and the research will come, but the things that some people use it for, like pain or mood and like sleep and like appetite, I don't really need a whole lot of evidence behind that to know that it works as a patient. So I think that when you're using it for some of these treatments that maybe we don't have a lot of solutions for.
Yes.
So I appreciate the stance on that, and the fact that the organization that I am within has come out and recognized the need for a medical system. So thank you for that.
That's great.
We have some questions, Anita.
Yes, we have a question that the viewer would like an answer from each of you. So from the patient perspective and from the rheumatologist perspective, what advice would you have for good communications between patient and rheumatologist? So I guess we'll start with Vandana.
Okay, sure. That's a really good question. Good communication is important in the doctor-patient relationship. Some of the things that help is also that patients can sometimes come prepared to visits. Bring your medications, make a list of medications, talk about what you've done perhaps in between visits, and think about healthy lifestyles and those kinds of things. In terms of our communication, sometimes we don't always, sometimes when a diagnosis is given, what we don't realize is that may be so devastating to the patient that they're really not listening to a whole lot that we're saying afterwards. So need to take a break and need to also offer advice in many different ways, and sometimes the repetition is also very helpful. And then repeated visits can also build upon that knowledge and so forth.
So we've developed over 26 years or so. I think
been that long?
Yeah, it's actually been that long.
Yes.
So I can't remember so much of early days in illness, but it's exactly as you say that I was tuned out to this for a number of years.
Mm-hmm.
So you've probably seen me as the guy that's sitting in your room wanting to get back to work,
Mm-hmm.
not asking many questions and just taking a prescription. I saw fantastic physicians, so I put a lot of trust in those people and yourself. But now, I come out and I show you my watch or my phone, and we see how active I've been. If my inflammation levels spike too much, you give me a call.
Mm-hmm.
So I think from a patient perspective, I've been I probably tried too many things to try to, but at the end of the day, I end up with things that stick. So I think it's really important to kind of take your way to journal, whether that's an app. Make yourself accountable. Exercise is so important. If your exercise is good, your appetite is better, your nutrition is better, everything works better. So try to track yourself and keep yourself accountable to exercising your way every day. And then journal so that you know what are your most important symptoms. I went probably 10 years without identifying fatigue as being a massive issue of mine, right? So pay attention, unlike what I went through, but get to know your condition and speak with other patients.
And I think also that, if I may add something, come prepared to your visit. And that's a lot of times that piece is missing. The patients, I think as a patient, you do have a little bit of a responsibility to take medications as prescribed, know and understand them, making sure that you're leading healthy lifestyles, all those kind of things that we do recommend, but take an interest in that, and that will make you a lot better.
Anything else? Okay, so that's it. As far as this year's CRA, Allied Health Professionals Association annual meeting, we are complete from Montreal. Thank you so much, Dr. Ahluwaila, and I'll
Pleasure
see
being
you
here.
in the office.
Yes, thank you.